Hello, everybody. I'm Rob Wallace here in St. Paul, Minnesota. I'm an evolutionary epidemiologist with the People's CDC, here with an update on the COVID-19 pandemic. This is the second of our two-parter this week. In the first part, we reviewed global COVID and U.S. COVID, as well as cover the latest in long COVID and what Americans are saying about their new COVID infections these past couple of weeks. In the second part, we'll unpack the Biden talking point that we don't have to do anything about COVID because, quote, we have the tools. We have the tools has been a Biden administration talking point back to September 2021. It's likely out of former presidential medical advisor Anthony Fauci's office. In decades previous, Fauci used similar language around organizing efforts to defeat the HIV pandemic. But while that previous cry aimed at rallying support for making antiretroviral therapies available to all infected with HIV, this version, repeated across the administration from former CDC Director Rochelle Walensky, former COVID response czar Ashish Jha, and now new CDC Director Mandy Cohen, appears more a rationale for avoiding the combinations of non-pharmaceutical interventions employers have adamantly opposed as a matter of reopening for business first and foremost. And as a result, as this classic of a tweet first posted in 2022 makes clear, doing nothing, or at best the very minimum, is somehow unable to quash a global pandemic of a novel virus our immunity is unprepared for. Such a louche contradiction is playing out in even our most august venues. After months of muffling COVID news upon Biden's declaration the pandemic was over, the New York Times ran two front-page stories on the virus late August, one day after another. The first profiled 3 people post-infection, including fine-grained 3D maps of their ravaged lungs. Quote, Andy Muniz, 36, of La Porte, Texas, was a welding inspector who enjoyed kayak fishing before he contracted COVID in July 2021. He spent over 6 months on an ECMO machine. These lungs are not capable of sustaining life, is how Dr. Howard Wang, who treated Mr. Muniz at Houston Methodist Hospital, described a lung scan taken 6 weeks after Mr. Muniz was infected, end quote. The second Times story reported the summer COVID surge in conflicting detail. Uptick in COVID brings reminder virus never left, after the Times itself helped create that very impression. Cases generally mild, read the print version of the headline, while also, quote, hospitalizations rise. If we evoke the parable of the drowning man here, drowning man keeps rejecting people's help, looking for gods, as if these people weren't God's intervention. If we evoke this parable, it isn't out of a cringy hubris, but a hope we all can make it back to shore together. For my co-authors and I offered chapter and verse to the effect that the fault in this bipartisan abandonment of public health was neither in ourselves nor in our stars, but in our SARS, by which we meant this structural moment when late neoliberalism meets its socio-ecological collapse, including the emergence of new diseases like COVID-19. For against the Times' muted warning, COVID traces a systemic refusal to acknowledge, much less act on, what we spent much blood and treasure to learn this pandemic. In the first part of our COVID This Week episode, we described new work detailing the next-level damage SARS-2 is inducing across a wide population. There really isn't such a thing as short COVID, is what we're learning. Yes, there's an acute infection to start, but just about all of us are still hosting viral replication across our organ systems years after our initial infection. The worst of the resulting long COVID counts off into the tens of millions of American cases, along with neuropsychiatric damage, vascular and pulmonary fibrosis, micro and macro clotting, gastrointestinal and pancreatic dysfunction. The virus is now shown to change mitochondrial gene expression, upregulating some genes, while downregulating others in the powerhouse of the cell. In other words, the virus hacks the very firmware of our cellular existence. And that is far more than a matter of inducing exercise intolerance and out of proportion fatigue. We're talking organ failure for many. The Times tells us what we feel about the COVID fad, whether we feel it or not. Quote, most Americans, more than 3 months after the Biden administration allowed the extirpation of the 2020 declaration calling the coronavirus a public health emergency, have shown little willingness to return to the days of frequent testing, mask wearing, and isolation, end quote. But also switching back to those lung scans, the Times shares, unable to breathe, Ms. Marlene Rodriguez required 2 months on ECMO. She developed a pneumothorax, or air trapped between the lung and the chest wall on each side. The air needed to be drained to prevent lung collapse. 2.5 years after her infection, Ms. Rodriguez can accomplish most daily activities, but she becomes breathless and wheezes when she carries her toddler daughter or does chores such as mopping the floor. She uses an albuterol inhaler for tiring tasks like climbing the stairs, end quote. And Ms. Rodriguez isn't alone. In the first part of our episode, we shared what we learned Americans are saying about their new COVID infections this past month. Here's a few more to underscore the point that so many are getting hit so hard. I think I caught COVID after 3 years. I've been so careful. And anyone who knows me, I wear a mask everywhere. This is the sickest I've been. My body's shutting down. I fucking hate this. I've had COVID 4 times this year alone. Last week marked the 4th time testing positive for COVID. My husband and kids only had it once, and that was 2 years ago. Here I am, isolated once again, wondering what is going on with all these attacks. Here's another. My husband and I got a positive COVID test Sunday. They were literally mad at him for missing work when he returned yesterday. Didn't even care we had been sick. We are both still recovering, and they made him return to work. Here's another. Nobody who can't afford to stay home for a week is going to stay home anymore. I'm so livid at the amount of neglect to this issue. It's turned into a wild west for most of the population. Hope they have a plan if this gets bad again, because the last one didn't work. I got COVID from a coworker who refused to get tested because they couldn't afford to stay home. Thanks, government. You have effectively promoted don't test, don't tell. Is this the new solution? Here's another one. My 3rd time with COVID, struggling to eat. Each time I've had COVID, my stomach hurts extremely bad, and I get super nauseous. And trying to eat makes it 10 times worse. I've tried ramen, smoothies, hard-boiled eggs. I've had to pause so I don't vomit. Can't finish anything. Barely can take 2 bites or sips without the overwhelming nausea. I don't want to lose weight. I've been trying to keep my weight up. Here's another one. Well, I got COVID again, LOL. 1,000 times more miserable being hella pregnant. Here's another one, a little bit longer. 104 fever, hallucinating, disassociating, and involuntary speech. I didn't realize until this morning how bad my day was yesterday. I woke up at 2 a.m. feeling sick, but I thought it was a cold. I thought this until 5 p.m. Around 9-ish, my fever went from 101 to 103, and I have no clue when it turned to 104, but I know I woke up, realized what I felt like, and that wasn't good. Checked my temperature, took a photo, and then fell asleep immediately after. I was hallucinating stuff around the room and where I was. I thought I was at my grandpa's house when I was younger and tucked into a Winnie the Pooh bed with lots of blankets around me. I kept hearing myself saying random words or noises, and I didn't understand what I was saying or anything that happened around me. All I knew, I was making that noise. I remember being awake occasionally every so often. This happened for about 3 hours, and I remember waking up quite a bit. I don't know why I woke up, not questioning what had happened. I woke up and all I wanted to do was take a shower. I feel fine now, just congested and coughing. I don't really know what happened or why. I didn't go to the hospital. I've had all my shots except for the most recent booster because everywhere I went couldn't do it. Here's a few more. And I know I'm going to some depth in here, but it's really important to hear what your fellow Americans are saying about these infections. Can you be put on opioids for severe COVID pain is the question. I've been hysterically crying for the past 2 days every hour because Tylenol, NyQuil, and ibuprofen does not work. I have never felt such intense and brutal pain in my life. I really don't know what else would help or give me some sort of temporary relief. Very scared, got hypertension, tachycardia thanks to COVID. This is another one. It all started in my last trip home. The lady sitting beside me was very sick and the flight helpers wouldn't allow me to change seats. A couple days after arriving home, I was sick with COVID for the first time. I have an oxygen saturation and pulse device at home. And on my first day with symptoms, I was already very bad, 75 oxygen and 160 heart rate. Ran to the hospital, and now I'm very scared since the doctors can't find a culprit aside from corona, and I don't know what to do. And my heart rate keeps worsening, and I'm on oxygen. I'm so frustrated. All these years, I was super careful and wore my mask, took 5 doses of the vaccine just to get COVID this bad. I'm 23. I really don't want to die. Fuck. Here's a couple more. Avoided COVID-19 until just now. My mom and brother got it just a few days ago. Despite quarantining and masking and hand washing, I've also got it. Largely, it feels like the cold or flu. The worst part, though, is the sore throat. Feels like I have a golf ball with a razor blade stuck in it every time I swallow. Anyway, it's only day 2. I've had all my shots, so if this is what mild feels like, then yeesh, I've got a new understanding on how horrible this is. Now, we're going to stop here. Now, if earlier this summer, the Washington Post was cherry-picking quotes in favor of the end of the declaration of the public health emergency, perhaps the People's CDC is cherry-picking here in the other direction. But unlike the minimizer program, we aren't claiming all is well. That is, to use a philosophical trope, we aren't claiming that all swans are white. We're just saying or showing that there are plenty of black swans out there. That is, plenty of people getting really sick. That the claim that all is well is false. The point here is that we have the tools, acts as a placeholder for the kind of governance Americans actually need, rationalizing instead in favor of doing nothing to keep the Marlene Rodriguezes and millions more from getting infected in the first place. Indeed, not even getting them vaccinated, the putative replacement for all those non-pharmaceutical interventions the U.S. abandoned. This was our percent population with an updated booster as of May 11th, when CDC cut off sharing these data. Hardly the kind of coverage for even the kind of herd immunity minimizers claim, much less for a virus that continues to evolve out from underneath vaccines and natural immunity. Especially when the darkest blue on the map is only for 25% of the population or more. This was to be our major tool against the SARS-2 virus, rationalizing the end of nearly all non-pharmaceutical interventions, including inside hospitals. And what of these tools? We've long known COVID vaccines don't offer sterilizing immunity. You can be vaccinated and still get infected. A Yale team reports to what degree we can still be infected, at least under Delta and Omicron. The team conducted a rolling matched cohort analysis of Connecticut inmates who were incarcerated between June 2021 and May 2022. SARS-2 exposures were divided into 3 events: exposure within a cell, exposure within a cell block, and undocumented exposure. The team identified the prior infection, vaccination, and hybrid immunity status of inmates across the 3 exposure events. We see here for both Delta and Omicron time periods, and top to bottom for all 3 sources of potential protection, prior SARS-2 infection, vaccination, and hybrid immunity, still produce non-zero hazard ratios. Significantly so for exposure within individual cells when the other inmate was infected. Vaccination and hybrid immunity, being previously infected and vaccinated, wasn't enough to protect inmates from such infection. The Yale team recommended exactly what the near entirety of the political class abandoned: contact tracing, masking, and other non-pharmaceutical interventions. The team writes, quote, "These findings suggest the benefit of layered interventions in general, and particularly within densely packed social settings. In the presence of leaky vaccines, non-pharmaceutical interventions have been proposed in tandem with vaccination in order to reduce exposure and mitigate infection spread. Such interventions may include social distancing, quarantine and isolation, masking, and improved ventilation and airflow." While our findings are obtained from the investigation of correctional facility system, the team continues, in the presence of a leaky vaccine, layered interventions may afford a benefit to other congregate settings and community settings where prolonged, close contact with infected people may occur, such as mass gatherings, end quote. With the new BA 2.86 lineage now emergent, it wasn't clear whether the once-a-year vaccine based on XBB 1.5 would control the new strain. A FDA official shared undue confidence that the vaccine would work. Based on what criteria is unclear, but the administration refused the official the right to go on the record to that effect. Now, tests are starting to roll in post-Labor Day on the new booster's effectiveness against BA 2.86. Moderna reports its booster is effective against this new strain, as well as the now circulating EG5 and FL 1.5.1. But running last-second tests like this doesn't seem like a model of public health moving forward. Regardless of whether BA 2.86 becomes a threat, the Washington Post reports, Eric Topol, the director of the Scripps Research Translational Institute, said the potential mismatch underscores the folly of attempting to annually update vaccines for an ever-evolving virus, end quote. Topol champions the no guarantee of a variant-proof vaccine, like, that unlikelihood would be wonderful. But another possibility is to stop pretending COVID is like seasonal influenza and go back to releasing new boosters tied to new COVID strains as they emerge throughout the year. Even should the boosters work, they may not be available to the general public now. The CDC's Advisory Committee on Immunization Practices will vote September 12th whether to recommend new boosters from Pfizer, Moderna, and Novavax. If the committee approves them, the boosters will be available mid to late September. But PBS News reports here the updated booster is slated for high-risk groups only, including people age 75 or older, pregnant, or immunocompromised. That's it. It isn't clear whether this is just a recommendation or whether doctors' hands will be tied by this. But the message is clear. We have the tools, but not for you. But even for those who do get a crack at the new booster, with the public health emergency over, the COVID vaccine program is being spun off into the commercial market. The CDC set up a new public-private program with pharmacies to cover the uninsured for this round of vaccination. But the vaccines, now suddenly $130 a shot, will be late arriving at the pharmacies, not until mid-October. Why? Because Roll Call reports here, quote, the government hasn't been able to finalize partnerships with any pharmacies, end quote. The CDC said uninsured and underinsured patients could find the shots at community health centers and state health departments, but such centers aren't always easily accessible, with vaccination already much lower for the uninsured. The slipshod nature of the stopgap is remarkable for a first world country. Roll Call reports, quote, when the CDC announced the Bridge Access Program in July, it had yet to figure out details about vaccine acquisition, distribution, reimbursement. And this is where it's hitting a snag. The CDC said it intends to reimburse pharmacies for the vaccine administration fees as part of the program, Roll Call continues, but pharmacies are still working out if that reimbursement will cover their costs. Pharmacies also do not yet know how many vaccines they will receive from the agency and when, end quote. So to sum up, we have a late, expensive shot, even after the U.S. spent $30 billion of public funds on developing the vaccine. As Health Affairs describes it, this jury-rigged operation violates equal access on 3 accounts. The Bridge Access Program, launched in July to cover Americans who can't afford the $130 price tag, depends on a gentleman's agreement between the government and the 3 vaccine manufacturers, asking for, as an open letter from the Department of Health and Human Services describes, quote, a reasonable rate reflective of the value that manufacturers have obtained through U.S. government investment. Price gouging behavior takes advantage of the trust of the American people have in manufacturers through the COVID-19 response, end quote. The Health Affairs commentary notes that this is a moral appeal to drug manufacturers, which Americans across the political spectrum understand is ridiculous. Indeed, the commentary continues, there are no financial incentives, no enforcement mechanisms, and no penalties for failure to set reasonable prices. Recently, we have seen skyrocketing prices for drugs such as insulin brought down only through the sustained efforts of patient advocacy groups, political pressure, and passage of the Inflation Reduction Act of 2022, end quote. In fact, the commentary notes, the price per dose the government has paid has increased at every turn, from $19.50 for the first Pfizer dose and $15.25 for Moderna to $30.48 and $26.36. The $130 is exactly the price gouging Health and Human Services begged against. The commentary objects to the notion that availability and accessibility are the same. There's no guarantee the government will follow up with outreach and transportation such a vaccine campaign requires. The government expects the pharmacies to conduct the outreach, but despite the 4-5 ratio of Americans within 5 miles of a pharmacy, nearly 59 million Americans live in a pharmacy desert. And as we learn, the pharmacy option presently isn't going well. Finally, the Health Affairs commentary describes a gap in the supply chain built into commercializing the vaccine. Quote, Once the federal government relinquishes its primary role in COVID-19 vaccine distribution, data as to vaccine disparities may no longer be available in timely or comprehensive fashion, end quote. The feds will have to depend on the company's willingness to share data about their own failures on this account, which is a dubious likelihood. While the vaccines are getting bottled up by both government spendthrift and market failure, rapid antigen tests are themselves suffering possible logistical problems. There have been recent rumors of delays of days between the first symptoms from an EG5 infection and when the rapid test turns positive. Anecdotal data as described in this NPR piece running back to earlier in the year. The rapid tests suffer greater false negatives than PCR tests, but they also represent something worse at the level of the population. They trade in the convenience of at-home testing for the collapse of the capacity of public health departments to keep track of the numbers of infections out there in their jurisdictions. A third problem is the tests themselves may be an evolution's gunsight. The test doesn't depend on detecting the rapidly evolving spike protein, but the nucleocapsid protein it focuses on also evolves, if at a slower pace. Indeed, one test from Luminostics Incorporated has failed on these grounds. Now, the biggest problem, however, is user error. We're not lab technicians, and against rapid test proponents, the test isn't like a pregnancy test. There's a lot more that goes into getting it right. There's also evidence that the test is more accurate for people with COVID symptoms than without. If you have COVID-19 symptoms, NPR advises here, even if your test is negative, it's a good idea to be cautious and just stay home, end quote. But as the testimonials we just read make clear, many employers wouldn't approve. That's the whole point of their campaign, to force the feds to roll back COVID as a social phenomenon, even if the virus continues as an actual pandemic. In the other direction, a negative rapid test doesn't mean you're in the clear on multiple accounts. While a positive test almost certainly means you're infected, a negative test doesn't necessarily mean you're uninfected. Multiple tests should be taken, especially if some of the expansive COVID symptoms we heard Americans describe earlier are apparent. But a negative test doesn't mean an unidentified infection can't also replicate to a level of such damage as to cause long COVID. A Northwestern University study examined only 29 of such patients, but by extrapolation, quote, we estimated that there were approximately 10 million people in the first year of the pandemic in the US who are in this predicament, who got COVID, got long COVID, but tested negative for COVID, said Igor Koralnik, who led the study and is a chief of the Division of Neuroinfectious Diseases and Global Neurology at Northwestern Medicine, end quote. The implication is that a positive COVID test need not be criteria for treating people for long COVID. Indeed, there's an equity angle, quote, restricting access to care for long COVID to people who had established disease will disenfranchise and really marginalize people who are actually likely the most vulnerable among us. Stat quoted Zayed Al-Ali, a clinical epidemiologist at Washington University in St. Louis, who noted that, quote, people with fewer resources or who live in areas where testing is not easily available may have a harder time getting a diagnosis, end quote. Indeed, Stat continues, roughly 2/3 of COVID-19 clinics in the country do not accept long COVID patients without a known diagnosis of the virus, end quote. Now, failures in equity can compound in other ways. Pulse oximeters testing patient blood oxygenation have a race problem. A Massachusetts study showed in a cohort of over 3,000 patients in an intensive care unit, Asian, Black, and Hispanic patients had higher average pulse oximetry readings and so were administered significantly less supplemental oxygen for a given average hemoglobin oxygen saturation compared with white patients, even as other research showed BIPOC patients more likely to be hospitalized for COVID problems. The oximeter is engineered to assume, quote, that the only absorber of the light energy from the device is the hemoglobin in the blood, when in fact, skin pigmentation absorbs the oximeter's light too. So while pharmaceutical interventions are welcome, we need them and we need them improved, their gaps suggest it takes a combination of interventions to cover the holes any one intervention might have. Indeed, a Royal Society study of thousands of studies found social distancing and masking unequivocally reduced the spread of COVID infections, especially when used in the kinds of combinations the US has abandoned. One such intervention in the US was paid for, but largely went neglected. Better ventilation in schools and places of work would go far in reducing infection, particularly as both venues have been shown to be amplifiers in community transmission of COVID. In 2021, Congress allocated $122 billion to schools to deal with COVID, including improving facilities. The Times reports a recent CDC survey showed, quote, only about 34% of the school districts said they used any of the money to upgrade their heating, ventilation, and air conditioning systems. About 28% more installed in-room air cleaners. 8% said they installed ultraviolet lights, a more expensive and complicated method, and the rest reported no changes that would substantially improve air quality, end quote. Surveillance is meanwhile suffering more from the end of community testing and the end of testing upon hospital admission, as well as the emergence of rapid test users aren't required to report in. The wastewater testing in sewage plants is only at 10% of possible capacity in the US, one of the few countries engaging in such surveillance at any capacity. And wastewater experts, including Mark Johnson, who spoke at a People's CDC webinar last month, speak of plant manager antipathy, exhaustion, or indifference with the testing program. Earlier in the year, CBC reported reductions in wastewater testing in Canada. In part one of our episode, we spoke of the steep decline in the genomic surveillance, the genetic sequencing that alerts us to new lineages like EG5 and BA2.86. Yes, as the red box indicates, there's usually a time lag from isolating samples to sequencing them and uploading them. But the GIS-AID database's graph here indicates such surveillance has been in linear decline since last year. All these proximate problems in operationalizing public health are only markers of broader structural gaps in US society. An Idaho University team produced a geographically weighted random forest model to map which sociological factors impacted COVID outcomes here for 3 COVID waves, Alpha, Delta, and Omicron through April 2022. We see the local mapping for Omicron socioeconomics, vaccination rate, unemployment, being uninsured for healthcare, diabetes, and food insecurity, all markers of underdevelopment in the richest country in the history of the world. This is still a very American set of maps, missing much of the political economy underlying this contradiction. In contrast, a recent Brazilian study on leishmaniasis is characteristically more explicit about these matters. The Brazilian team writes, quote, the high occurrence of human visceral leishmaniasis in Brazilian municipalities with higher GDPs and human development indicators suggests that the amount of wealth generated and the quality of life of the population in these territories, measured by these indicators, are not in line with the needs of sustainable local development, since this development model involves a character that is not restricted to socioeconomic factors and income concentration, but encompasses its environmental, cultural, equity, and public policy conditions regarding access to basic rights, end quote. I know that sounds like a mouthful, but what we see here is that we can hear the collapse in access to public health and basic rights in the despairing voices of Americans getting sick with COVID that we quoted earlier. Being middle class or getting paid in the working class isn't protecting Americans from COVID. These COVID indicators are emblematic of the bigger picture that life expectancies in even the wealthier of US states are nearly a decade less now than other industrial countries. And the poorer US states like Mississippi, Alabama, West Virginia, and Louisiana are down around many countries of the global South, including Iran, Colombia, Peru, and Bangladesh. So while the rich in some countries are worried about shoddy public health only to the extent it might affect their profit, that's largely in places other than the US. For as we described in the previous episode of COVID This Week, here in the US, essential workers were sent right back to their infection, while so-called non-essential workers of the professional managerial class were allowed to protect themselves by remote commuting, using their computers at home, but also by using boutique COVID prevention services for their work or play events. We see the White House itself among event scan clients. They're using this service of pre-event health screening, on-site testing, vaccination verification, antigen testing, PCR testing, thermal scanning, that the White House claims the rest of the country no longer needs. Earlier in the year, we described the precautions the World Economic Forum took to protect its wealthy participants, including FFP2 masks, on-site PCR tests, rapid tests, HEPA filters, UV lights, disinfection multiple times a day, and an on-site wellness hotline. Such services are made available to the wealthy all along their travel routes, including these assurances listed here that staff transporting clientele to their private jets will be masked, vaccinated, and boosted, with facilities expeditiously sanitized. What a colossal wreck. There's a way around both the government's mass abandonment and its instrumentalized mindfuckery of telling us we don't need protection while the rich protect themselves to the gills. Our gang shared that the fault in our stars can be fixed by turning society back to servicing the public commons. Putting people before profits sounds like a tired utopianism only because it keeps coming up as a commonsensical reversal of a lucrative misanthropy both business parties and their media champion. Otherwise, it'll be long COVID in the millions in the normal post-COVID world, as the Times now named it in its article on the summer surge, where, quote, COVID is always going to be around. There's a way beyond naturalizing infection and death for everyday people. We need to organize ourselves around the public health everyday Americans deserve. Last month, retirees protested against New York City plans to shuffle off 250,000 retirees into Aetna's for-profit Medicare Advantage program, which would have limited medical options and raised prices. The protests work. A New York Supreme Court judge issued a final ruling against the plans, although the city is appealing. The People's CDC is involved in efforts at rolling back more COVID-proximate dangers, including this campaign demanding the new vaccine booster be made available to all ages and that boosters be made available more frequently. As we spoke of in previous COVID This Week episodes, the CDC's Healthcare Infection Control Practices Advisory Committee, or HICPAC, advises CDC on infection control policies. HICPAC is made up largely of healthcare management representatives and is subject to almost no public scrutiny. Policies are made with minimal input from patients or healthcare workers. And in that spirit, HICPAC is now aiming to strip out infection control protections in hospitals. The People's CDC is calling for rolling back such plans and getting Congress to impose greater oversight upon HICPAC, including prioritizing patient and healthcare workers instead of hospital profit margins. The People's CDC is waging a campaign to demand Congress and state legislatures promote the CDC's Increasing Community Access to Testing Program, or ICAT, to make the more accurate PCR testing for COVID free for all. The People's CDC is inviting the public to add its voice to telling CDC to support more wastewater surveillance. The People's CDC has also been advocating for the bigger picture public health Americans deserve. In quite the opposite direction of privatizing Medicare, the present administration is spearheading. One of the People's CDC's campaigns is calling on health workers to help champion universal health care, labor rights in the health sector, and broader health science education, among other demands. There's other work being done outside People's CDC. We're certainly not the end all be all of this kind of work. Local efforts out there in the world are trying to fill in what the federal government abandoned, including this New York City effort to get the city council there to support a bill providing free masks, PPE, and rapid tests through the mail. In other words, another world is very much possible, and people are fighting for it. Links at which you can contribute signatures and emails for all these campaigns are listed in the video description below. And that's COVID This Week. You can find all our episodes on the People's CDC YouTube channel. You can learn more about the People's CDC and read this week's COVID weather report at our website, peoplecdc.org.